Welcome to Variations 4, the gastrointestinal accessory organs unit. In this video, we'll be covering questions 13 to 20, still on the topic of acute hepatitis, cirrhosis, and talking about specific offshoots of the cirrhosis or severely scarred liver, such as portal hypertension, hepatic encephalopathy, ascites, and esophageal varices. So question 13, what is portal hypertension and how does it arise in patients with cirrhosis? So then this picture will help us answer question 13, and that is if you've got scarring, inflammation, and especially scarring of the liver, which is basically the definition of cirrhosis, scarring of the liver. It's basically a compressed area now in terms of blood flow. And it's difficult. These are major vessels. It's a highway of blood that runs through the liver because it has to turn over a lot of blood, every minute in order to metabolize, synthesize, work with what is ingested and what is in and needs to be taken out of the bloodstream. So it's a hugely popular organ for blood flow. If there's congestion because of the scarring, you can see here kind of by these squiggly arrows, blood is not moving through here as quick as it wants to and starts to back up. And so it's kind of backing up in the system. And you get this whole area is called the portal region, and you get a portal hypertension. And as we talked about earlier, that can cause a spleen to swell. And it can cause other problems too, which we are absolutely going to get into. And so the next question is 14. What effect does portal hypertension potentially have on systemic blood pressure? Or we can answer that right away. It can raise blood pressure. It might raise systemic blood pressure. Again, I want to stress though, even if it doesn't raise systemic blood pressure, it's still a problem in itself. Esophageal blood vessels, abdominal girth, and the spleen, and the peripheries. Explain each one. Okay. So let's look at the picture and see what we can cover off here. We already talked about how this could cause a spleen to become enlarged. It can also cause, roundabout where the esophagus meets the stomach, it can cause swelling of the vessels there as well. And what happens is these vessels start to bulge out, and they're called esophageal varices. And they're bulging out of vessels because they're so filled with blood. And the problem is that if anything scrapes against those enlarged vessels, like let's say someone has a really dry piece of toast, for example, doesn't chew it properly, it scrapes against these as it goes towards the stomach, it can cause major hemorrhage. So there's the esophageal varices and the spleen we've talked about. In terms of ascites, now you have to imagine this is the right upper quadrant of the abdomen. You have to kind of imagine the abdomen here. That's where the spleen, that's where the liver sits, right? Here's kind of the mid part of where the stomach is. And just imagine the whole abdomen here. This whole area of the portal area is around about your abdomen. That's pretty accurate. And so if you've got major pressure building in these vessels because of portal hypertension, what can that cause in terms of fluid shifts? Think about unit 1. It can cause hydrostatic pressure, which is increased pressure against the vessel walls, causes fluid to seep out into tissues, and in this case, the tissues of the abdomen become filled with this water portion of blood that's being pushed out by hydrostatic pressure, and you get what's called ascites. Let's take a picture. Let's take a look at a picture of that one. This is a pretty nice picture here of normal abdomen, normal peritoneum. Now let's throw in a little bit of portal hypertension and Let's throw in that portal hypertension that causes hydrostatic pressure in the vessels, pushes the water portion of blood out into the surrounding tissues, and you get this filling of the peritoneal cavity with this fluid. Okay, and the extremities are the same deal. If we worked our way down to the lower extremities, you would expect that if we're having a decrease in albumin, because the liver is not producing albumin, plus maybe throw in a little bit of hypertension, secondary to the portal hypertension, then in the lower extremities especially, you've got increased pressures there and decreased oncotic pull, and fluid starts to shift out, and you get a swelling of the lower extremities around the feet and ankles. Of course, map 10 and 11 do go through this as well, straight out of Lewis. And you can just follow the kind of arms down here, that there's your ascites, there's your esophageal varices, systemic hypertension. Again, there's offshoots from each one that you can look at yourself. But more or less, we have covered that. And then 11, same deal here we've talked about. Okay. So now if we look at question number 15, 15 is asking us which organ in the body synthesizes ammonia, which organ in the body converts ammonia to urea, which organ in the body excretes urea. This is really straight up some basic questions. So which organ in the body synthesizes ammonia, produces ammonia through metabolic processes? So, the ingestion of protein, it needs to be said, is a pretty key player in ammonia. The synthesis, the breaking down, the metabolism of protein will end up increasing ammonia in the body. Okay, and that actually, interestingly enough, the kidneys is a big player, and of course the gut as well, the intestines. Kidneys and intestines are both big players in terms of synthesizing ammonia. So the first part, the answer to the question is the kidneys and the intestines. They synthesize or cause the body to have increased amounts of ammonia circulating in the bloodstream. And again, just to be clear, I mean, one of our sources of ammonia in the first place is eating proteins that eventually get broken down and parts get synthesized into ammonia. The second part of that question is answered, and you already know that answer. It's the liver that converts ammonia to urea. So the liver converts ammonia to urea. Then, of course, the kidneys excrete the urea. Now, that's all that stuff's what happens in a healthy body. But that's all that question 15 is asking us to talk about so far. Question 16. So now, using what we learned from 15, let's talk about 16. What is the pathophysiology behind hepatic encephalopathy? If we go back to map 12 here. So now, of course, you assume that the liver's not working. So the kidneys are working, the gut's working, I assume. So someone eats protein, for example, it gets converted to, synthesized to ammonia, but the liver is unable to do what because it's damaged? It's unable to convert that ammonia to urea. So we have increasing amounts of circulating ammonia, which is problematic. It's kind of like a waste product in a sense, a byproduct of protein metabolism. When that crosses the blood-brain barrier, you end up getting neurological symptoms such as changes in level of consciousness, changes in level of orientation. We can make a list as long as my arm in terms of agitation, restlessness, the confusion, the delirium. But the big kind of sections are the LOO and LOC get affected. This is called hepatic encephalopathy. Okay, and we're going to come back to that, how we address that later. All the question was asking us is is hepatic encephalopathy caused? That's hepatic encephalopathy secondary to liver failure. And question 17 is just asking us to look at some key diagnostic procedures and around cirrhosis, basically. So let's look at map 13 for that. There's a few of them. I mean, you've got your obviously you can, where do we begin here? I mean, you can look at your serum markers, for example. Let's say you had a hunch that someone may have, they've got right upper quadrant pain, they're nauseated, they look really yellowish. You're thinking jaundice, you're thinking some kind of liver disease, you're thinking inflamed, enlarged, maybe scarred liver. I mean, you might have more background than that. 20 years of alcoholism, for example, like on and on, visited this country, not vaccinated for Hep A and C, blah, 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 on and on. And you start to think, well, we might be able to actually pick up on antibodies here for if it was Hep A or B, or whatever, Hep C. But then again, maybe it's not been 2 months yet. Who knows? This is pretty acute. So maybe we can get the antigens. Maybe we can pick up the antibodies. Maybe we don't from blood work because it's too early. But there's other things we could pick up from a damaged liver. We could find rising bilirubin levels in the bloodstream. Okay, we might see that. We might see liver enzymes being released because of damage being done to liver cells. These are all being talked about above. We might see that happening. Sure, cholesterol production might be down. That's a function of the liver. We might see lowered albumin levels, and thereby we might start seeing things like, ascites. You might start seeing things like swelling of the extremities. We might see clotting factors. We wouldn't see that. Well, what we'd see is INR and PTT going up because clotting factors are going down. We might want to actually grab some of the acidic fluid from the ascites and analyze it to see what's going on there. Of course, the doc will palpate. They might want to do an ultrasound. Okay, so there's like some quick workups. In the absence of being able to confirm what is causing the problem, we can certainly find other ways of diagnosing and looking at the problem. Okay, so the next question. Why is rest important for patients with liver disease? I mean, why is rest important for any patient, really? I mean, you want to decrease metabolic needs and increase healing. How do we manage ascites? So we talked about how ascites is formed in terms of fluid moving into the abdomen. Now it's asking us to talk about what are some of the management approaches for ascites. We'll look at map 14 for that. So you've got ascites. We've already gone over what that is. Maybe the docs put a shunt in there, which is basically something that diverts blood flow away from the hepatic region. Now that would certainly help to decrease portal hypertension, but the downside is it's also going to decrease blood delivery to the liver in general. And so it's going to be tough for the liver to do its job on things like, managing aldosterone levels, on things like changing ammonia to urea. These are a few examples. So it's kind of, if you can shunt blood away from the portal region, that's a good and bad. It's good because you decrease portal hypertension. It's bad because, well, then the blood doesn't really get to the liver, and how's the liver supposed to do its job? So it's a catch-22, but it's one thing. Another approach is the paracentesis, and that's either by a one-time needle or by sticking a drain in there and leaving it in and letting the abdominal fluid drain. As a nurse, you're going to be watching for what? Obviously drops in blood pressure. Why would blood pressure drop? Because that fluid in the abdomen has already left the circulation. Okay, it's already gone. And once you've got that fluid in the abdomen, you've got ascites, it's left circulation already. So why would blood pressure drop then when you empty fluid from a cavity that's already left circulation? If you don't know the answer to that, you need to review Unit 1 on fluid and lights. and go over the concept of hydrostatic pressure and our second explanation of hydrostatic pressure and why you need to be really careful when you drain body cavities too quickly. We might need diuretics to move that fluid out of the abdomen. And if we do, then we got to keep, track of and monitor our fluids and our lights. Whenever we have a lot of fluid on board and we give a diuretic, it's normal for a little while to expect output to be much greater than input. So if you're doing fluid ins and outs, that first little bit that you're starting someone on a diuretic, if they're mobilizing a lot of fluid out of tissue spaces, it is normal to see fluid outs being greater than fluid ins for a little while. We may need to give an albumin infusion to try and pull fluid from the abdomen back into circulation because albumin has oncotic pull. That might help a little bit. And if nothing else, it'll prevent fluid from flowing out of the blood vessels into the tissues again, but it won't last forever because that will be synthesized and moved out of the body in and of itself. And if the liver's not producing albumin, that infusion is only going to last a little while. Diet. Decrease your sodium so that you can decrease your blood pressure, so that you can decrease basically your hydrostatic pressure against vessel walls, if that's applicable to the patient. Okay, next question. Question 19, esophageal varices. We talked about those are the bulging varices roundabout where the esophagus meets the stomach. Big risk for hemorrhage if they get scraped or they just burst. Maybe they burst on their own. Who knows it? So first of all, if you did have an emergency where they burst, they do what's called a balloon tamponade, where they basically stick a balloon down here and they inflate it in the esophagus, and there's the stomach, and the coolness and pressure of it will stop the bleeding. It's obviously a temporary measure until they can, maybe they have to sclerose some vessels shut, for example. Maybe if they do what's called banding. Banding is when they tie off the bulging vessels so that if they burst, it doesn't completely bleed out. Let's take a look at banding because it does come up. It does come up again when we look at our concept maps. So here's a picture of them using the tool that they put down. You can see this is where the esophagus meets the stomach. They've got a varice here. It's a bulging out. You don't want anything scraping against that. They use this tool to put a band around it. And I'm going to be honest with you, to me, it looks like if you burst that, why wouldn't it still bleed through? Anyway, somehow the banding will stop the bleeding. It'll limit the bleeding if this did burst. So that's all I can tell you about banding. We do see patients that have in their cardiacs esophageal banding done. You probably still need to be careful not to give them a diet that's too coarse. You don't want to encourage any kind of bleeding here, but this will limit the risk here, this esophageal banding. So now just kind of looking at the concept maps, we already talked about not irritating the area where the banding is. You don't want to, you want to basically treat any kind of coughing or sneezing even to try and, you want to try and decrease pressure in the varices. That's tough to do, but you want to avoid upper airway infections, avoid straining or lifting. Certain beta blockers will actually decrease portal venous pressure. So you might see some people with liver failure who have hepatic increases in portal hypertension. They might be on some meds like beta blockers that will decrease pressure in that area. I imagine that they would probably have systemic hypertension too to be getting this med, but it does help. Of course, I want to remind you that, again, this decreasing of blood flow to the area causes increase of things you don't want, like ammonia, because it's unable to reach the liver for conversion, if the liver is even able to do that. Propanolol is an example of one. All right, and then bleeding varices we've talked about. Obviously you're at risk for hemorrhage, And so there's kind of all these things you can do if you have an emergency bleed, from scleropathy, which is, basically burning the vessel shut, to the balloon tamponade, which I just showed you a picture of. They might need blood products. Okay. When you think of nursing interventions around each one, well, I mean, some of them you're just kind of standing by. You're not doing the balloon tamponade, but you're obviously, monitoring airway and that kind of stuff. If you think of the blood products, well, think of everything we talk about in INP about blood and IV administration. That's your responsibility for monitoring and stepping in if there's an emergency. Just doing your general monitoring. You got a patient who's got esophageal varices, you need to be aware of the risks and be monitoring blood pressure, monitoring LOC, the usual QPA stuff you do with the risk of hemorrhage in mind. Okay, then finally, question number 20, talking about how we treat hepatic encephalopathy. Let's go to map 16 for that. So remember, hepatic encephalopathy means you've got that ammonia circulating, crosses the blood barrier of the brain and blood-brain barrier, and you've got this confusion, altered LOC, LOO. Decreasing protein is a good thing. You don't want to eliminate protein. The person still needs protein, but you got to decrease it because this contributes to ammonia synthesis. Increasing carb and decreasing fat. I mean, that's just kind of, they need energy they've got increased metabolic needs. They need high energy food, but you don't want to give them something that's too fatty, because especially if the bile duct is blocked, you don't want that. And you want to decrease protein as well. So here's a big one for you. So how do we get rid of this ammonia that's circulating, this excess ammonia that's circulating? We actually give lactulose. Now I know you think of lactulose as a laxative, and sure, it definitely is a laxative, but that is not the purpose of it here. In fact, when the order is written for lactulose, it'll actually say, give lactulose for a goal of 3 to 5 bowel movements a day. Now, if you're seeing that as the goal, and it'll say that right in the MAR, if it says that right in the MAR, then we're not giving this for constipation. We're giving this because the patient's got increased ammonia levels, and we're trying to remove ammonia through the GI tract. And so when you see that med, you don't want to be saying, oh, lactulose. Oh, yeah, but the patient already had a loose bowel movement this morning. That's the wrong way to look at this particular situation. You need to look at the patient background and say, okay, 3 to 5, that's because they've got liver disease, they've got encephalopathy. When they have the third bowel movement, I'll stop giving the lactulose today, and we'll keep track of ammonia levels by way of blood work. Also, by way of all those bowel movements, watch your potassium levels and, of course, your fluids. Might need to give some of those fluids and potassium. So here is an interesting one. When when you have to limit protein because of encephalopathy, you might be switching to TPN, total parenteral nutrition, for the patient, because it provides protein that is more easily metabolized by the liver. That's interesting. Just something to consider on the side. I'm not exactly sure how that decreases circulating ammonia levels, so I can't answer that question. You may have that. You need to maybe read up a little more on that if you're interested. It's not something I see particularly often. I see these patients on a limited protein diet, though.